Welcome everybody to our weekly medical grand rounds. And before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. And just as a reminder, next week we are recognizing National Orange Shirt Day, which is later in the week, but the entire week there are a number of events that hopefully you'll get an opportunity to participate in, both on the university side as well as from Alberta Health Services. So I'm delighted to introduce our speakers today. The first one is no stranger to us. Dr. Miyazaki was the first director of equity, diversity, and inclusion for our Department of Medicine, and the former division director of neurology and zone section head for neurology in the Edmonton zone. She currently holds a new position as zone clinical department head for neurosciences within AHS. She's published works on EDI since 2018, including the progress of women in neurology and at the American Academy of Neurology. Our second speaker is Dr. Sarah Burton-McLeod. She originally is from Nova Scotia. She came to Alberta for family medicine residency, and after working as a family medicine locum, briefly, she returned to finish a third year in palliative care medicine. She's the residency program director for both the enhanced skills in palliative care as well as the new adult palliative care medicine programs. In addition, she also works in the Office of Advocacy and Well-being. Okay, I thought it was well-being, providing support for undergraduate students in the FOMD. Sarah truly believes that the palliative approach to care is something everyone in healthcare can help to provide. Clinically, she's part of the palliative care consultation teams in the acute care hospitals in the Edmonton zone. And I'd like to take this opportunity to welcome her to our Department of Medicine Grand Rounds and thank her for this. Over to you, Janice.
Thank you, Norman. So we will pass by the land acknowledgement, which Dr. Kassam did. So today, I'm going to discuss one example of palliative care in internal medicine, specifically in neurology, and even more narrowly in neurodegenerative diseases, and the opportunities for academic productivity, because yes, palliative medicine is slow medicine. So you're going to have to take time to do it, but I feel it's very rewarding, and many of my colleagues feel that it has been an antidote to burnout. And then to introduce a new program for internal medicine at the Royal College Diplomates at the University of Alberta, and existing partnerships of palliative care and neurology as an example. So often we think of primary palliative care skills. There's no easy way I can tell you this, so I'm sending you to someone who can. And sometimes I actually get these referrals, like, this person has a very poor prognosis. Can you tell them that? Or this person is asking about MAID. Can you have that conversation? And in fact, almost every week I'm having conversations about MAID. And palliative care is also a team sport. So we practice palliative care in neurology as an interdisciplinary practice, not a multidisciplinary practice. So let me explain what the difference is for those of you who may not be aware. So interdisciplinary means that all the members of the team are in the room assessing the patient at the same time. They come up with a joint plan, and the patient gets that one plan. In the United States, they do not like this model because it's not very remunerative. In most of my colleague centers, they have a round robin. Patient sits in the room and the physicians rotate among them so they can see 6 patients in a half day. We see 3 patients in a half day. And I would not be able to do this program without Dr. Ingrid de Kock, who listened to my pitch for it and said, well, that was obvious. We should all be doing that. Instead of the usual response I have been getting, which is neurology patients never die. So she was the one who really listened to what I had to say about my patients and said, let's get started and work together. And Daniela Butenschön, who comes to the clinic all the time, who is up here. Dr. Caroline Deutsch, who is a pastoral counselor, but has a PhD in psychology. Our nurse coordinator, Jeanette Amin, and Dr. Wendy Johnston, who sees all the ALS patients. So this started while I was at the University of Toronto, and it seems so long ago, but in 2012, I published this paper. I will tell you that things are a lot easier now for non-cancer people to publish in palliative medicine. When I submitted this paper, the response from reviewers was, this shows Canadians don't know how to look after Parkinson's disease, and this program can only work in a socialist country. This paper was published through a grant from the Parkinson Foundation because they felt that it was important information. So they had to pay to have it published in a peer-reviewed journal. That's how brutal it was. I shopped this around in 20 different journals and got rejected because it was so new and it was so different. But now this is accepted. So I kind of paved the way for y'all to not have to get those objectionable and unprofessional reviews. And what did we show? Well, we showed that, in fact, our patients with advanced Parkinson's disease had scores that were similar to people with metastatic end-stage cancer, and that after brief ambulatory palliative care, they could have the similar improvements in symptom control. So this is really quite striking because in the past, people did not really understand that patients with neurologic disease had the same amount of suffering as people with metastatic cancer, which, you know, if you go to Joe Blow on the street, he'll say, yes, people with cancer suffer. But do they say, yes, people with Parkinson's suffer or people with dementia suffer? Not to the same extent. And we also showed that the Zarek Caregiver Burden Scale, which we modified because one of my patients' spouses called to tell me her husband had raped her. And this is part of the impulsive dysexecutive changes that happen in patients, so they become physically and sexually aggressive. So again, other sources of suffering for our families who are struggling to care for their loved ones at home that we need to acknowledge and we need to shine a light on and normalize so that they can disclose to us and we can help them. And when I came here, I had a fellow who looked at decisional capacity for advanced directives in Parkinson's disease. And he examined 50 patients who had impaired decision-making. So they said, you know, all these patients, actually 50 of them said, I'm not as sharp as I used to be, but they all scored normally on the MoCA, which is pretty sensitive. So technically they're not demented, but 20 out of 50 of them actually had impaired decision-making despite having this normal cognition. And it was because they really couldn't explain their understanding and appreciation of the information we were giving them, but they could express a choice. And so again, it's a sign that we should be having discussions that could be challenging earlier on because patients will lose capacity and then we may be following instructions that don't really fit their values. Then one of my mentees got a huge PCORI grant. So this was quite outstanding, $2.5 million for palliative medicine. Who knew you could get that? And this is a branch of NIH, Patient-Centered Outcomes and Research. And he looked at 3 centers, 2 in the United States and our center. We followed 210 patients over the course of a year, randomized to usual care, which was the neurologist and family doctor, or palliative care, which was movement disorders neurologist, palliative care input, and spiritual care. And we all had a different model of care, which was interesting because we all showed a similar signal and improvement. And what improved was the symptom burden as measured by the Edmonton Symptom Assessment Scale for Parkinson's, which is the scale that I developed with my original palliative care physician, Jackie Huey, who is now at the University of Calgary. Health-related quality of life, grief, caregiver anxiety, motor symptoms, even though we weren't to adjust their Parkinson meds, they actually felt better. And completion of advanced directives increased from 26% to 56%, 53%. And in terms of caregivers' perspectives and what impacts the caregiver's health, we also looked at what was impacting poor outcomes for the caregivers. And it was a sense of grief, loss of their relationship, loss of the person they had married or of their parent, income, presence of an additional caregiver, recent ED visits, and use of counseling services, which probably is a marker that even we knew that there was something bad going on, so we referred them on. And predictors of spiritual well-being. So this has been a long-term interest of mine. After a rabbi came up to me and said, "You don't know who I am, you don't know what I do, but you need me." Her uncle had multiple system atrophy, and she realized that many patients had spiritual distress. And she felt that spiritual care should be offered in the ambulatory setting. When I came here, initially at the K, they said, "Oh no, they go to their faith provider in the community." And I explained, a spiritual counselor actually has very intense experience in the hospital, and so they understand about crisis, health crisis. Your spiritual provider in your faith leader in the community comes to give you last rites. That's not exactly helpful. What we need is to actually address hopelessness, despair that many of our patients have. Many of our patients follow our instructions well, and they continue to progress. That is true hopelessness, and we need to help them with this. So in our program, we had 183 dyads, and in fact, what was very predictive of better spiritual well-being was caregiver factors of depression and anxiety. So when the caregiver was depressed or anxious, they tended not to help the patient with their spiritual distress because they're distressed. But if the patient expressed faith, if they had lower symptom burden, better health-related quality of life, which was strongly associated with a caregiver being present, they reported less spiritual distress. The other thing that we talked about was optimizing future planning. So I know many of the neurologists in the audience will know this phrase: everyone is individual. We can't really predict how you're going to progress. This makes us feel good that we have answered a question. It does not make the recipient feel good because they are no clearer about what's going to happen in the next 6 months or next 1 year. And I think that this became clear in this qualitative study where the usual care group felt they didn't have a team. They felt that the caregiver was most often the captain of care and had to be proactive about getting information, whereas the palliative care group felt supported by the team, identified the neuropalliative care physician as captain, and they felt they had a roadmap and guide for their journey. And, we weren't brilliant, like we weren't doing rocket science. We were just helping them predict what would happen in the next 6 months. And they don't expect you to be perfect. That's the other thing. I think as physicians, we think, oh, I have to give the perfect answer. And if I give the wrong answer, it's going to be bad. No, they want you to at least give a broad estimate about what are the best outcomes and what are the worst outcomes that might happen. And for them to understand this range so that they can plan to move from their 3-story home where the full bath is on the 3rd story to moving to a condo where everything is on 1 level. And it takes about 2 years for that to happen. I mentioned about sexual and physical aggression, and this was a paper at the top by one of my fellows in Toronto. And then it was replicated in our 3-center study. So in fact, the same percentage of people, about 26% report physical aggression, sexual aggression, and 30% report physical aggression. So many of the centers that I coach to implement palliative care say, we know our caregivers so well, we don't have to use the survey instrument. And I ask them, are you detecting 25% of your caregivers are being sexually abused by the patient? Oh, no. Well, then you need to use the survey instrument. So that's the other benefit is you can take your clinical experience, right? That one patient telling me this, but also several care partners when I did caregiver education events, they came up to me and they said, yes, this is happening so much. And it's the dirty secret of Parkinson's. And we all talk about it, but we don't talk about it to the neurologist because they don't want to hear. Think about what a lonely place that is for the spouse. So you take your clinical experience and then you prove it to the world, because when I started talking about it, everyone goes, what are you talking about? These are really rule following people. They aren't going to do stuff like that. And so I proved it. And then they all went, oh my God, it's so obvious that this would be happening. Oh, okay, thank you. Anyway, so now it is really well known that this is happening to our care partners. And in fact, when I started talking about it, the president of the Movement Disorder Society at a patient panel said very distinctly, when I make a diagnosis of Parkinson's, I tell them you better find something else to die of because it's not going to be Parkinson's, he said directly to me. So the president of my own society was saying, this isn't happening. But now that was only 6 years ago. So now we did a survey of all the movement disorder members. And in fact, you can see here that it's almost 90% of members believe, either agree or strongly agree, that palliative care is really applicable to our patients. And that, in fact, they also indicated they want to learn more about it so that they could incorporate it into their centers, which is totally awesome. And what also makes me happy is that they're not just talking about end of life, but they're talking about symptoms like pain would be applicable, having challenging conversations, talking about continence and sleep problems. So they're actually broadening what they view as unaddressed symptoms in movement disorders that we can help our patients with our palliative care colleagues. And this is a paper from Alberta using our Alberta informatics. And over a 5-year period, we found 1,439 people with neurodegenerative diseases died. 46% died in an acute hospital, 36% in long-term care. But 64% of these decedents had more than one hospitalization in the last year of life. So you think about the cost that goes along with this healthcare utilization is very high. There was a very small amount who were admitted to the ICU. And this is also surprising. Only 37% saw a neurologist, and oh, that's really so disappointing. 8.8% saw a palliative care specialist. So even though we have now a clinic in Edmonton and a clinic in Calgary, there aren't enough people who are getting to it. And this is a recent review paper that we did in the Lancet Neurology that talks about total pain, total suffering from neurologic diseases. And you can see that it includes the physical, social, practical, emotional, and spiritual changes and challenges that we have, because our patients are often having this kind of course where they are having more and more symptoms as time goes by, and that we need to be better at helping them with it. And of course, we all know that our patients are coming in with multiple comorbidities, and most of these are also associated with having a poorer course with their primary illness. And so I'm going to pass it over at this point to Dr. Burton McLeod so she can talk about our new program that we're very excited about at the University of Alberta.
Thank you so much, Janice. And can I just start by saying that really it is because of the trailblazing work that you and others have done that we actually have this program. And also that this program is very much a team effort. And well, let me see, am I going the right direction here?
Oh, sorry, that was mine.
Oh, I'm sorry. Do you want to speak to this one?
Yes,
I
apologize.
I'll be right back.
I apologize. So to emphasize the academic productivity that you can have, I have had over 150 papers published since that awful experience in my first publication, and my H-index is 55. So when people say that doing palliative medicine is something sort of soft and it's not really academic, that is not true. It can be truly an academic endeavor, and people make their careers on this. And in the last year, I've had 2 published texts. I have 1 textbook in production, and I received the Lifetime Achievement Award from the International Neuropalliative Care Society. And if you are the first one in your institution to start this, you have an opportunity to be a leader and to be a mentor to others. And that's really way more than the prizes, way more than the papers. It is who you touch, so that there's a little bit of you in every person that they're going to touch afterwards. Being a mentor is the greatest opportunity, and doing palliative medicine is a wonderful opportunity to be a mentor.
Thank you so much. I totally agree. And speaking of mentorship and training, we're really excited to be able to introduce this new program. Adult palliative medicine is now being offered at the University of Alberta, and we're really excited about that. As I say, this was complete team effort, and really because of the work of others who've gone before myself and others who've been involved in this, that actually this came to be. So just a tiny bit of history. As you may know, we actually had a conjoint program initially that was accredited by both the Royal College and the College of Family Physicians. I actually trained in that program back in 2005. And just a few months before that program dissolved, I became program director. So in any event, because it was a one-year program, yeah, I know the timing wasn't exactly optimal. However, I did learn a lot very quickly. And so as it was a one-year program, we were able to adapt it and align it with family medicine, make sure it was housed in family medicine, and we could continue that one. However, to offer the Royal College program, we had to make a completely new application because it was, in its intent, supposed to be a completely new program with, and I think this is key, a really huge focus on the delivery of non-cancer palliative care. And this was something that, being honest, in my training in 2005, it really wasn't an emphasis at all in my training. Although on reflection, I think about family medicine residency. I was based at the Royal Alex. I saw patients dying my age of talc lung. And then early on in my career, Dr. Wendy Johnston and Sanjay Kalra invited me to help collaborate in the ALS clinic. And that was really formative time for me. So I think myself or my colleagues, over time, we have really recognized that this is where the need is that we were really not meeting. So in any event, we did make an application to the Royal College. I say here that it was not approved. I think completely declined would be more accurate. So we went on to make a second application, and we were granted new program status in July of 2022. We weren't quite ready to go into CARMS yet. And so this year we finally have, and I'm happy to say we just had a round of interviews, in fact, this past week. So that's kind of been a snapshot of the process. I would say I've learned a lot. That first application, you know, in hindsight, I really did have a ton to learn. And I'm so grateful for, you know, other PDs, the PGME office that really helped mentor and guide me through that second application. And I think help us deliberate and put a lot of thought into what we really want to do with this program. So why do we care so much? Why do we persist? Why do we keep applying for it? Because in the end, right? It's always about our patients and their families. So we're recognizing that societal need. And in fact, I just mentioned briefly here that the Canadian Society of Palliative Care Physicians back in November of 2016 made a position statement aptly entitled, I believe, How to Improve Palliative Care in Canada. And at that time, projecting the need with the aging population, they actually said, look, we need to actually immediately double all our residency training programs because we're nowhere near being able to meet the need that is coming. So I think part of this was an attempt to recognize that need for patients and families. And then in particular, as I say, our patients and families need experts in non-cancer palliative medicine. And that was not my training, but I know that it's needed. And there are so few people that do have a background and then an intense training in this field, such as yourself. So the other piece is that academic palliative medicine, as you said, Janice, is so very important, and we need to continue to collaborate and move this forward. And I think we need always the best evidence to inform the care that we're giving to our patients and families. And so I think we really wanted to make sure that we had this as part of the educational offerings here at the University of Alberta. So essentially, there may have been a bit of stubbornness for some of us in this, but it's not just that. And it's not just because other schools have it. It's really, truly about what our patients and families need. So just quickly to mention the eligibility requirements. These are the official feeder programs: internal medicine, hence being here today, anesthesiology and neurology. And to say that if you have Royal College certification or enrolled in one of these programs with the option to potentially complete that final year in training if approved by both PDs, then these are definitely to be considered. Evidently, entry from other specialties may occur, and I'm aware that has occurred across the country as well. Emergency medicine, for some reason, seems to be fairly popular for applicants in any case. So what is exciting about this program? What is new about the program? I just wanted to mention a couple of things here. Not that they're necessarily unique for this residency program. I think they're quite common across the board. But when we sat and thought about what really mattered, what we wanted to make an emphasis here, this is what we thought about. Obviously, we thought about the palliative approach. And for sure, we know, like our group, we do not own this. We're not the only ones doing this. Matter of fact, in the hospitals, you are the ones providing the palliative care, and sometimes we come alongside to help if needed. In the communities, family physicians, nurse practitioners, the teams there. So we know we're doing, I think, a fraction of the actual palliation in the zone. So to be clear, we know we don't own that, but it is a lens that we use every day in our clinical care. Of course, I mentioned we want to emphasize care for our patients facing serious illness that is non-cancer, even though we all grew up in a time when the emphasis was still very much on oncology. We also, being that now this is a 2-year program as opposed to the conjoint program, which was only 1 year, there's time for additional emphasis on research, leadership, teaching skills, which I think are things that we all know would be very needed for a successful career going forward in academic medicine. We really wanted to be very intentional. Social accountability, I think, clearly is important for every residency training program, but I think what we wanted to look at is, what about the quality of the care we're delivering? How can we improve what we're doing in terms of social accountability? And then we also recognize that, well, wellness, well-being is very, very important. And even though I work in the Office of Advocacy and Wellbeing, I actually had gone with the sort of somewhat older version of wellness program when we developed this for our enhanced skills program, and tried to build on that and make sure that we're preparing people not just for a career in academic palliative medicine, but a very sustainable and fulfilling career too. Just a really quick note about the overall rotation structure. Of course, there are core blocks, there are longitudinal outpatient clinics, many of which are collaborative in nature, such as Dr. Miyazaki's, that will be throughout year 1 and year 2. And there are 4 blocks dedicated to only non-cancer illness. And that was very intentional. So I heard that internists sometimes like more detail. Don't worry, I have more detail. So the curriculum map in an overview, and there's one that's and yet more detailed than this, but just to say that for those of you who are also quite visual as I am, you can see there are various palliative medicine rotations at various sites with various teams. There are off-service rotations in medical oncology, radiation oncology, and pediatric palliative care. And there are also the longitudinal clinics. And because our colleagues in the neuropalliative clinic, it's so well established, it's so well known. And so we asked them, could we please use this for our very first year? And can we send you our residents? And they have happily agreed, and I'm very grateful. And you can see we will talk about some of the other clinics in a bit more detail, but we also have longitudinal clinical experiences with pulmonary medicine and hepatology as well. I wanted to just quickly mention the piece about social accountability. And I would say here that it's not that these cogs are necessarily supposed to represent any sort of order or priority, but just more that I think to some extent they are interconnected and intersect. So I think that these are things that I personally want to work on and continue to work in my practice. And I think as a group of colleagues, we also decided that this was something that was very important for us and wanted to build in with a lot of intention into this program. And so cultural safety, I personally prefer cultural humility because I think that resonates with how I like to approach my practice and my patients, excuse me. Deep respect for diversity. I think this is really key. And we have so much to learn. I have so much to learn. And as Canadians, we really need to continue to work towards the work of reconciliation. And I will just share from one of my patients recently, words that I think I will always hold. He said to me, he was Indigenous and he knew people who had been involved in the work of the Truth and Reconciliation Commission, who had in fact drafted the calls to action. And he said to me, you know, what is the good of this if no one is held accountable? We worked so hard. If no one's held accountable, what did we really do? What did we really accomplish? So I guess I just pass that on and intend to pass that on in the program from what I learned from my patient, because I think that each one of us, both individually and as a system, need to be held accountable in terms of the work we're doing. Wellness, another piece that I really wanted to talk about. As I mentioned, we had developed a program with the Enhanced Skills residency, and this was really honestly the work of two of my colleagues who are psychologists, one of whom is now retired, and Dr. Nikolajchak and Dr. Leesky Hansen were really key in developing a series of seminars that they have around this program. And then also there are actually carved out days, 2 per year, for wellness activities where residents are not accountable to report back to us, but they need to do something that will help promote their wellness. We also took the very robust fatigue risk management from PGME and adapted it for our field in palliative medicine, recognizing that it's not just the physical fatigue so much as the emotional, the psychological, sometimes even existential, I would say, fatigue of watching that suffering. Now, I will absolutely agree with Janice that being able to walk with our patients is deeply meaningful, very fulfilling, and actually often I find does give energy, but it also sometimes, some days, feels like it takes a lot too. And we recognize that. So we wanted to build that recognition in. And we also, as a tool to help mitigate that and deal and process with some of that emotion, we have a narrative reflection program as well. Just quickly to mention, not everyone will necessarily want to do this program, even if they are interested in palliative care. So what might be some other opportunities? Of course, I know Dr. Miyazaki has spoken so well to the neuropalliative clinic, which is an incredible opportunity. Dr. Deirdre O'Neill, who you may know being a rock star, has also not only cardiology subspecialty, but has trained also in geriatrics and palliative medicine in the States. And she will be returning from parental leave soon. And Dr. Mina Kaluri and I have recently started collaborating in her ILD clinic, as well as Dr. Panita Tandon and Dr. Amanda Brisebois have been collaborating now for some years in hepatology. So these are things that they're going to be key rotations within this program, but we're hoping as they become more and more established in the case of the ILD clinic and hepatology that there'll be other learning opportunities for others as well. And of course, we have our traditional selectives in palliative medicine and our usual rotations. To mention, if people were interested, of course, there's always the serious illness conversation workshops. Many of us are facilitators for that. I personally have found it really, really helpful in my clinical day-to-day practice, and it's offered online out of Calgary and Edmonton. Pallium Canada, you may have heard of. It's a research or nonprofit group, sorry, not research, but medical education is actually their focus. They have a lot of really great materials, and their handbook is one that we recommend, although there's a cost to everything, unfortunately. And of course, there's lots of palliative care conferences, so I just list a few in case anyone was interested. And I also wanted to say thank you to every one of you, because aside from the inspiring work that I mentioned before that Dr. Miyazaki and others have done to pave the way for this opportunity, I also know that many of you I have spoken with, run things past, look to for encouragement, especially after the rejection. And I just really want to thank everyone, and fellow program directors in the PGME office, staff and faculty there in particular. So I will hand back to Dr. Miyazaki here.
So in conclusion, I actually think palliative care is the best part of medicine. I really do. You know, I love teaching DL foundations because that's what we were all like when we went into medicine, right? They're so keen and excited, and they want to be kind and good to the patients. And somehow that gets a little squeezed out of us as we go through residency. And palliative medicine allows you to tap into that again. There are many opportunities for non-cancer specialists to expand its use, both through primary. So what I do, because I didn't get a palliative care fellowship, that's called primary palliative care, and specialist palliative medicine, which the new diplomates from the Royal College will be specialists in palliative medicine. And it's really increasing in the States in neurology. We have probably over 100 people who are double boarded in neurology and palliative medicine now. That academic careers can be built on palliative care and internal medicine, and it is a great opportunity to mentor our trainees with interest in palliative care.
And just ask a couple of questions. So first of all, really great to hear that the training program has been rebooted. We've got a few, I think you know, Amanda Brisbois went through the program. There's others from the past. So just a question around logistics. How many residents are you going to be taking? And internal medicine is a little confusing. So we have, you know, sort of the 3-year core program, and then there are all our subspecialty programs. So will entry into palliative care be after the 3-year core program, or is it after subspecialty training? So we've actually got, like, you know, something like 12, 13 subspecialties in internal medicine. So can you just clarify that for the learners? And then I have another question.
Oh, super. And thank you. And am I still on?
Sorry.
Oh, no worries.
Back on.
Oh, thank you.
Can hear
Technology. Okay. Thank you. Great question. We're only taking one per year at the moment. We have post-COVID some issues with teaching capacity, and we want to make sure that we can offer the best training for everyone. We will take applicants in core family medicine.
Sorry, family medicine.
I'm sorry, internal medicine. I'm so sorry.
After their 4 years, you'll take them, because they were not part of our subspecialty match this year. So that's why I just wasn't sure. So we may need to clarify that offline or something.
Yes, absolutely. So we did enter to take, yes, I apologize for my slip up there. Internal medicine core applicants. We only just interviewed a couple of days ago. And then my understanding is that we would consider subspecialty as well, but that would be in addition to, right? So a much longer period of time.
We need a little clarification on that, because we just had our subspecialty match numbers and palliative care wasn't included in there. So that's why I'm just a little confused, but we'll clarify that offline.
Yes.
And then, and thank you for, you will consider post subspecialty.
Yes, absolutely. Okay. And I think, you know, even return from practice, assuming that PGME and Royal College are okay with it.
The second question is around what Janice touched on in the conclusion, which is that so-called hidden curriculum, right? So you talked a lot about wellness and fatigue risk management and so on. And, you know, in speaking to junior learners, there is this, and, you know, remembering my own experience, right? There is a certain thickness of skin that develops as you look after sick acutely unwell patients with multiple comorbidities and all the rest of it. And not everyone's going to have the opportunity to do either a palliative care elective or a rotation or a residency or whatever. Do you have any thoughts, either of you, as to how we can embed this into the curriculum, right? Yeah, I'll leave it at that.
Yeah, that's an excellent point. And in neurology, what we've done, because we have Wendy and myself, we usually give them a month every 2 years of education, and we emphasize challenging conversations, the approach to dealing with family conflict, which, if you think about it, that's a large part of the angst when you're on service, right? Like the families who have conflict about how we should proceed. And so being able to navigate that is really key. And palliative care specialists really have great skills at immediately figuring out what's going on with the family and helping to navigate it. So the palliative medicine, what the movement also is to ensure that every specialist has some palliative care skills, and that we shouldn't just sort of say, oh, okay, you're dying, I'm going to pull out my palliative care skills. It should be part of you. And I think that once you start practicing it, it was interesting. The person who has been most successful of my mentees is Benzie Kluger. His initial statement when he came to a seminar was, I came to see if this was total bullshit. I've decided to make this my life. And he said, it's interesting because you can never extract the palliative part of yourself once you start doing it. And I think that's really true. And I think that if, as more and more subspecialties start to require palliative skills, primary palliative skills, because we'll never have enough palliative care specialists to provide all the palliative care. So we actually have to ensure that all of us, and that means nurses too, and physiotherapists and occupational therapists and speech language pathologists, they all have to have palliative skills so that we can provide primary palliative care. And then we know when we must refer on to specialist palliative care. Like when the pain just gets so unrelenting and you're past the comfort level for opioids for yourself, that then you ask for community palliative care consultation, or you ask for a grade nuns admission. You know, we're lucky that we have grade nuns. We have fewer hospices. I just found out in Calgary, they have 9 hospices, and we have what, 3? Oh, 6. We have 6. Okay, I exaggerate. But so I think that's it. We all, in every specialty, we have to start to embed primary care skills, primary palliative care skills.
And undergrad, I hope.
Yes.
Yeah. There's just a couple of questions. So the first one is around your patient population is not always, but quite often elderly, multi-comorbidities, and so on. And so the question is around opportunity for including geriatricians in the work that you do. There was just a mention that, you know, there was no mention of geriatricians. So maybe just if you would comment on, you know, where geriatricians fit into the whole opportunity within palliative care.
Definitely geriatricians have a role in palliative care that is starting to emerge now in the literature. In our clinic, in fact, we have an embedded geriatrician. And so what we have done in our practice is help her to create, ask her to help us to create capacity. So what we do is once patients are past the age where they will benefit from device therapies, we transition them to her. And I trained her. So she did 7 years with me, half a day a week for 7 years. And she is very good at dealing with MSA and PSP. Some of these conditions are not very common, and many geriatricians won't have experience. So I think, in fact, although geriatricians are also in short supply, embedding a geriatrician in many of the internal medicine specialties is actually useful, because it can help create capacity to bring in new patients, but not have the patients who are past the point where you can do advanced therapies feel that they've been abandoned by their primary subspecialist. So I have always had her in my practice at U of T, and I was very glad when her husband became CMIO here, so she would come and help us out in Parkinson's. But I agree. I think there should be a geriatrician in every internal medicine clinic.
And Sarah, to your point, are there any required geriatrics rotations, or just speaking to, you know, they do a lot of this, you know, so
Absolutely. Yeah, you're absolutely right. And I do think that there is certainly a lot of commonality, I think, in terms of certain patient populations that we would also see. Though it's not a core rotation, I think our hope is that we really want to build more collaborations, and especially the outpatient clinic setting, because I think that it would be even better if we could offer more subspecialty collaborative clinics. So absolutely, we're very happy to, and we're hoping in future years to reach out and perhaps work on something there.
yeah, thank you.
Oh, and I should mention that in the UK, Australia, and New Zealand, palliative medicine is actually provided by geriatricians. So they have been natural leaders. Many of the big names in palliative medicine have been geriatricians based on that. So there's a very strong history.
Can we stop screen sharing just so people, oh, you have, okay. Just so people can see it.
Yeah, we
okay, thank you. Are there any questions in the audience before I go back to online questions? Yeah, Vince.
You have to have a C level of care to be
A compassionate,
No,
can you
no.
repeat the question?
So the question for the people online is, do you have to have a C-level care to be palliative? So technically, to be admitted to the hospice, yes, you do need to be C. But to receive ambulatory palliative care, you do not. And so I saw a patient yesterday who was an R1. She's very adamant that she was going to be an R1, and I've been following her for a year. We do it based on need and symptoms. And again, this is different than the United States. We should be so grateful we're in Canada, because in the United States, what we call home care is called hospice, and there's a 6-month limit. And once you survive past 6 months, you are often delisted, which is traumatic to the patients and families. Whereas in Canada, I have many patients who have received home care for like 3-5 years before they pass away, and it's based on need. So I think we have a much more humane system.
And so you're referring to palliative home care, because obviously we have regular.
Okay, palliative home care should not go on for 5 years. We have home care. Our home care is actually their hospice, if you can believe it. That's the same services they get. Palliative home care is very specific. So you have to have specific palliative care needs. And that's the other reason why the interdisciplinary clinic has been really helpful, because I'm not boarded in palliative care. So to have a palliative care specialist say, yes, this person should receive palliative home care, because then you get enhanced drug benefits as well, and enhanced equipment benefits. Services. So yes, that should be a shorter period of time, but you won't be delisted from palliative home care.
Do you want to add to that, sir?
Oh, yes, thank you. And just to say, I do think that things are shifting a lot, because I think when I first started training, I think there was that kind of, idea that if you weren't at least M, maybe C, then probably we weren't involved. But now in the acute care teams, quite routinely, we're seeing patients who are our level of care, because a lot of it is, as you say, the symptom management, the conversations, that we can, sometimes it helps to tag team, to like work with the team in challenging situations, especially with really challenging family dynamics. Sometimes it helps to have more people involved, sometimes it doesn't, but we're happy to draw alongside any treatment modality. And just to say, yes, with palliative home care, and not that we're the arbitrators of that, though, that regular home care can themselves refer to palliative home care at the appropriate time. So you don't necessarily need us to have palliative home care involved, but they're an amazing resource.
Did you want to follow up?
Well, I've had the experience in hospital where the patients being refused to be seen because they weren't C level of care. And I think it's a missed opportunity, where the people it's where they really need it. By the time someone sees, I mean, I can jack up the nerves pretty easily myself. But when it's earlier on, I think it's like hugely preventive.
Thank you for that. And I'll just repeat that unfortunately, was shared that there's been some refusal, I think sounds like from my colleagues potentially, to see a patient at some point until they were C level of care. I'm sorry. I think that really what we want to do is really make sure that we're in there. I think sometimes we may be a little short and we may not get there for a few days, but we always want to be there to help. And we will see any patient with any designation if there's potential need.
Was that recent?
It's multiple times.
Okay,
So I had it in my head, it was a requirement.
okay, no, it shouldn't be a requirement. Maybe they see my patients because they see my name as the referring person.
They will see.
But you know what,
patients,
yeah, so Sarah will just check on that and confirm so that,
I have.
Yeah, I think the only time is around if the question was solely hospice, because for that one, you do need to be C to go. And there are occasions where we're consulted multiple times just because of turnover in teams with the same question about hospice and the patient's family are adamant about M1. Then I think we sometimes say, okay, call us back when they're C. But I think that should be probably, even then, we most usually would come. But I'm sorry if there has been some miscommunication around that, and I can pass on to my colleagues that that's the messaging and that we not really what we were wanting to message. So apologies.
So there are a few more questions. One is similar to the one about geriatrics, where asking about primary care practitioners not being mentioned in the programmatic approach, and wondering that, where's the role for primary care to provide palliative care, and, thinking about overall in terms of cost to the system, and, having primary care physicians with those skills that could continue to follow their patients.
so in fact, the expectation in Alberta is that all primary care providers can provide a certain amount of palliative care. And they might get assistance from the the community palliative care consultative service, as well as from our clinic. So we often, because you have to have a single prescriber of controlled substances, we will often send the instructions back to the family doctor, and I usually write it in bold. Dear Dr. Smith, could you consider prescribing X at this amount and this amount of breakthrough? And I literally write out the whole prescription for them. All they have to do is like copy it. And so there is an expectation that primary care providers are part of the palliative care network. And that's really strongly embedded in Alberta already. And they have a different pathway to residency certification. So they take a 1-year extra certification to be certified as palliative care specialists.
Oh, thanks. Yes, thank you. That was what I was just going to say, just that I didn't dwell too much on the other program that we have, being the Enhanced Skills in Family Medicine, because it is a separate program, even though the origins of both programs were originally that conjoint program in the beginning.
And that program is still available, the Family Medicine Enhanced?
That's right.
Yeah, okay.
Yeah, so that one continued throughout, and that is still available.
Okay.
And we're taking between 1 to 3 residents a year for that,
Right.
depending on our resources. So.
The other question was, I don't know if you're familiar with the Royal College ability for practice eligibility route, like PER. So when and my understanding is it's only with new specialties, but when there is a specialty available, current FRCPCs that are doing that work or may have gotten some kind of training can apply through the practice eligibility route. So it's a broader question asking, is there a pathway for current FRCPC physicians to obtain palliative care Royal College certification? I think I know the answer, but I'll let you respond.
I think I know the answer to, but I should probably start and then hand over to you. I know that for sure there is a practice eligible route. And in fact, those of us who were in the field, even though our primary training might have been in family medicine, because at that time the thought was we didn't realize that the programs would be separate, and perhaps we would have picked internal medicine and gone that route instead if we had known. So under certain circumstances, depending on your years of clinical practice and so forth, and when you started, some of us may technically be eligible. So I'm certain then that Royal College physicians should be eligible, but
No, I have nothing more to add except to say that they should write to the Royal College. Yeah,
exactly.
to be recognized.
Oh, that's excellent. Do you have to take an exam?
You
We
might
have to take an exam, but you maybe don't
You-
have to. I don't know. Do you have
Well,
to?
in general internal medicine, you do. So I suspect in palliative care, you would have to as well.
Yeah.
So, there is another question, since we have a little bit of time. I'm assuming no more questions in the audience. So I'll go here. Okay. In the UK, although most people in hospice will be C, hospices will admit people with other goals of care if there are challenging symptom management issues to address. Is there scope for this in Edmonton, or do patients have to be C level of care? And then a little bit about jurisdictions in the UK. Palliative care is trying to be involved at a much earlier stage before the patient is declining significantly and has developed challenging symptoms. In this way, palliative is more the whole patient journey. Do we have similar pathways in Edmonton?
Absolutely. And I think we actually learned a lot from our colleagues in the UK as well, I would say. And certainly we want to be involved early and earlier than we were in the past, and for many reasons. I think there are a lot of different models of palliative care delivery, and it varies widely even within Alberta and across the country and certainly internationally. And I think for in terms of our resources here, we do have our 6 hospice units in various places around the area. But we also have our tertiary palliative care unit at the Grey Nuns, where we're limited in that we have 20 beds, and it serves, the catchment area of the Cross Cancer Institute, of course, which goes up into the territories, as well as the zone here. But I did work there for, I think, 7 or 8 years. And it was really such an amazing time in my career. And I really appreciated working there with amazing team. But yeah, you can be admitted there with M1 or M2 goals of care. In Calgary, I understand that they will admit patients who are our level of care, and they will run codes on the unit. But that's also because they have a slightly different model of care, and they have, I think, a unit that also has a lot of their very intensively treated cancer patients. So there's a lot of variability, but that's how things go in our again. But we're happy to be involved with the care of patients who are our level. They just wouldn't be eligible for our unit.
Yeah, and so in our program, because we're a little more established, we do see patients who are probably M, or even R1. As I said, I saw someone on Tuesday who's R1. And it's really dependent on symptom management and trying to get as much supports for the caregivers as possible. So, and the other model I like to think of is a semi-permeable membrane, so that the patient can enter when they have existential distress, then they go back to their usual specialist, and then if they have a hospitalization or a crisis, they can go back through the semi-permeable membrane to palliative medicine. And so many of us are trying to develop that kind of weaving in and out so that we don't. Sometimes there is a tendency that people will say, oh, this person has progressive supranuclear palsy, palliative medicine, and they're still talking and driving. So I can't, that's a long time to follow that person.
All right, so I'm sorry, maybe, okay. So on behalf of the department, I'd just like to take this opportunity to thank you both for an outstanding presentation, a great opportunity for further training and enhancement of skills and so on. So congratulations on that, and a great presentation. Thank you so much.